Hello, my name is Wiriyaporn Ridtitid. I am in the Division of Gastroenterology, Faculty of Medicine, Chulalongkorn University and King Chulalongkorn Memorial Hospital, Bangkok, Thailand. On behalf of Professor Rangsan Ruknimit, who is the corresponding author and all co-authors of this study, I would like to share our recent paper in gastrointestinal endoscopy on bacterial contamination and organic residue after reprocessing in duodenoscope with disposable distal caps compared to duodenoscope with fixed distal caps, a randomized trial. Current standard of duodenoscope reprocessing consists of 5 steps including pre-cleaning, leak testing, manual cleaning, high-level disinfection, and drying and storage. Despite of adequate reprocessing, several outbreaks of multi-drug-resistant bacterial contamination have been reported in duodenoscopes with fixed distal caps after standard reprocessing due to its complex elevator mechanism. In 2015, the United States Food and Drug Administration, or FDA, has recommended adding at least one of the following supplement methods of duodenoscope cleaning to reduce the risk of bacterial contamination after reprocessing, such as double high-level disinfection, ethylene oxide gas sterilization, and liquid chemical sterilization. However, based on previous studies, there was no significant benefit of these supplement methods of duodenoscope cleaning on the standard reprocessing. In addition, the FDA has recommended either surveillance or per procedure microbiological culturing and quarantine to ensure free of bacterial contamination after reprocessing. However, in real practice, every procedure use of culture is not feasible due to the 72-hour waiting period for culture results. Recently, the adenosine triphosphate or ATP test is widely accepted as reliable audit tool for duodenoscope cleaning. Our previous data had proposed an ATP threshold of 40 relative light units or RLU to ensure the effectiveness of high-level disinfection, given its sensitivity of 100 with a negative predictive value of 100 for bacterial contamination. Since 2020, FDA has recommended newly designed duodenoscopes with disposable components to improve cleaning the elevator backside. However, the data on the contamination rate of duodenoscope with disposable distal cap after both manual cleaning and high-level disinfection are still lacking. Therefore, we conduct this randomized trial comparing bacterial contamination evaluated by culture between the duodenoscopes with disposable distal caps and duodenoscope with fixed distal caps after manual cleaning. We include 400 duodenoscopes with fixed and disposable distal cap used for ERCP procedures during the study period. All used duodenoscopes were randomized into 2 groups, 200 per each group. Group A duodenoscopes with fixed distal cap and Group B duodenoscope with disposable distal cap. After manual cleaning, samples were collected from the elevator at the rest and lower position using a sterile swab and were submitted for culture and then ATP test. After the initial high-level disinfection, samples from the elevator were submitted for ATP test. If the ATP levels 40 RLU or greater, the duodenoscope was returned for an additional cycle of high-level disinfection until the ATP result passed the threshold. We measure the proportion of confirmed bacterial contamination by culture after manual cleaning as the primary outcomes. And the secondary outcome included mean ATP level after manual cleaning and post high-level disinfection, and the proportion of potential bacterial contamination using the ATP threshold 40 RLU or greater after HLD. We found that after manual cleaning, duodenoscopes with fixed distal cap had a significantly higher proportion of bacterial contamination compared to duodenoscopes with disposable distal cap. 14% for duodenoscopes with fixed distal cap and 7% for duodenoscope with disposable distal cap. After manual cleaning, mean ATP level was also significantly higher in duodenoscopes with fixed distal cap compared to duodenoscope with disposable distal cap. After initial high-level disinfection, the proportion of potential bacterial contamination using the ATP threshold 40 RLU or greater after high-level disinfection in duodenoscopes with fixed distal cap was 2.7 times higher than duodenoscope with disposable distal cap, but did not reach statistically significance. 4% for duodenoscope with fixed distal cap and 1.5% for duodenoscope with disposable distal cap. The conclusion of our randomized trial is that duodenoscopes with disposable distal cap provide significantly lower rate of bacterial contamination and organic residue after manual cleaning compared to duodenoscopes with fixed distal cap due to its ability to access to the backside of the elevator for more meticulous cleaning. Only a few duodenoscopes from each group did not pass the ATP threshold after high-level disinfection. However, our study tests only one design of a duodenoscope with a disposable distal cap from a single company. We did not include other designs of duodenoscopes such as duodenoscope with detachable cap and elevator in this study. Therefore, additional studies are warranted to test other designs of duodenoscopes. Recently, a single-use duodenoscope has been developed to eradicate all bacterial contamination in duodenoscopes and clinically validated in several studies. However, based on a recent cost-effectiveness study, due to its cost and utility standpoint, using duodenoscope with disposable distal caps was the most preferred strategy among many strategies to minimize the risk of duodenoscope-related infection, including standard high-level disinfection, double high-level disinfection, ethylene oxide gas sterilization, culture and quarantine, duodenoscope with disposable distal caps, and single-use duodenoscopes. Since the cost of ERCP procedures are different among centers, further cost analysis are required in each center to confirm these outcomes. Thank you.